Now, there allegedly is someone that's supposed to be a moderator for my session, but I'm perfectly happy to introduce myself to cut down on the time. I'm Michael Speer. I've already introduced myself as the chair of the executive committee of the TCHMB. I'm also a professor of pediatrics and medical ethics at Baylor College of Medicine and Texas Children's Hospital, where I'm a faculty neonatologist. I have few claims to fame, one of which I'm working on my 230th neonatology fellow, so far as training, and I've been at this officially for 43 years. So with that, we've heard some preliminary information, and I'd like to sort of expand on that in what's new with TCHMB, except for many of you it's not new, it's old hat, which is perfectly fine because it should be. That means we've inculcated the precepts that we favor. This shouldn't be a surprise to anyone. This is the 2019 March of Dimes outcome, premature birth report card outcome based on 2018 data. You can see down below or on the screens that Texas has earned a Royal D. What does that mean? That means that the prematurity rate in the state of Texas for 2018 was 10.8. The best that Texas has been was in 2015, which is 10.2, which is somewhat elevated compared to the goal of 2020, which is 8.1. You notice there is one state gets an A. There are a number of others that are Bs, those are the dark green. But you can see in the South, unfortunately, that's where the prematurity numbers rise. Parenthetically, this somewhat duplicates, not totally, but somewhat duplicates those states that have and have not expanded Medicaid. So take that as a food for thought. Looks like I have a timeline issue. Anyway, TCHMB did not spring from the forehead of Zeus, fully clothed and muscled. It was a process. It started back in about 2010, maybe even slightly before that, when Texas Healthy Babies, Healthy Texas Babies, a work group was established. That work group tried to figure out what areas in perinatal medicine in Texas that needed to be improved, how could we start doing it, what should we do to move forward. The deliberations of the Healthy Texas Babies resulted in some white papers. Those white papers in turn led to the establishment legislatively of the NICU Council. The NICU Council, when it first met, figured out very quickly that neonatologists and pediatricians were kind of lost in the framework of the horizon unless we involved obstetricians and fetal maternal medicine. That in turn led to some other legislation being passed, which turned out to be the Perinatal Advisory Council, which some people are aware was the group that came up with the rules for NICUs and for maternal care across the state based on ACOG and AAP recommendations. And in that, the Healthy Texas Babies morphed into the Texas Collaborative. So we're somewhat incestuous, but that's probably a good thing because we can network all among ourselves. We don't need anybody else. In November 2015, the UT Health Science Center in Tyler, in partnership with the UT system, sort of began providing support to the TCHMB so far as administrative resources. And we contracted with DSHS for a contract renewed through fiscal year 2021. Now, how is Texas unique? Well, we're here, so that's one thing. Secondly, we are the second largest state. I've heard rumors that people want to chop off the Aleutian Islands and maybe cut off Alaska around Point Barrow. to bring it down to size, but that doesn't seem to be gaining any traction. There are approximately 400,000 births each year in Texas, a little less in the last couple of years. That tracks the U.S. data, as you've already seen, but it does represent 10% of the births in the United States annually. 1 in 5, we are one of 5 states that are a minority majority. What does that mean? That means the minority population exceeds the majority population. Now that makes a little weirdness, doesn't it? But those areas of population that have been classically thought of minorities are now the majority. That's the bottom line. Reflecting that, 35% of the population speaks a language other than English at home. We have more counties than any other state. I'm not too sure that's good or bad. In both urban and rural Texas, 95% of the population is in less than half of the counties. So many counties in Texas have a paucity of medical care. And we have 3 of the 10 largest cities in the country. So what is the Perinatal Quality Collaborative? That's the PQC. The Quality Care Collaborative has been established in a number of states, led by California. We shouldn't look down our noses at California. They do some good stuff. We just need to recognize the good and the bad and pick what's appropriate. But the collaboratives across the country are to advance healthcare quality and patient safety for all Texas mothers and their babies through the collaboration of health and community stakeholders. You notice it's health and community. The healthcare people in this state cannot do everything. It is the community as represented by all of you, in addition to the healthcare providers, that can provide answers and solutions. So the executive committee sort of heads up the TCHMB. We've got a lot of people with a lot of talent and a lot of expertise, and they come together, as already noted, 4 times a year to discuss projects, to propose new projects, to review the data on the older projects, and you can see the number of bullet points there that represent partner organizations. I'm not going to read them all because you have 2 eyes and you have a brain and you can figure out what they say also. Leadership structure is the executive committee. We have 4 subgroups: community health, obstetrics, neonatal health, and data. Currently, the data is being constituted so that we do it right. This is with the advice of the state. Our community health partners have decided that they are going to be a resource for obstetrics and neonatal care and help move projects such as AIM out into the community with more success than if we, the healthcare people, were doing it on our own. These are current members of the executive committee. I'm going to leave this up just a touch so that you can take a picture if you want to complain or compliment any of the members on the committee. We are and should be held to your standards, not necessarily ours, that there is a lot of talent on the committee, and a number of the people on this committee are sitting next door to you in the audience. So what are the goals? The goals are to reduce preterm birth and infant mortality. Sounds simple, but as you've already seen by the data presented, it's not simple, it's very, very complex. Secondly, reduce disparities and reduce maternal mortality and severe maternal morbidity, and reduce disparities in the health outcomes of mothers and babies. This involves improving the health outcomes of mothers and babies and increasing the involvement of families and fathers, which is an area that has been neglected over the last several decades. And lastly, to improve women's health throughout the life cycle, not just during pregnancy, not just immediately after giving birth, but throughout the woman's entire life cycle. So how are we doing this? Collaboration, you've already heard, is probably job 1. Data-driven assessment that can support the collaboration and the projects. Quality improvement methodology, which has been proven to improve outcomes no matter where employed, and education and communication. It's one thing for me to stand up here and say we need to improve. It's another thing altogether to get the population behind what we want to do. These are some of our past initiatives. The print is small, but the little boxes seem to help. Reducing failed induction of labor. 20 years ago, people routinely asked the mother, well, how do you want to be delivered? How quickly do you want to be delivered? Do you want to be delivered vaginally or by cesarean section? There became a subgroup of mothers that said, well, you know, I'm going on vacation on November 3rd. I'm getting back on November 15th. Can I be delivered November 16th? That would work in with my lifestyle. Well, that may work into lifestyle, but it works into intensive care units for the babies and potentially for the mothers. So that's changed. It's taken us a long time to change that. But elective inductions are a thing of the past. Increasing breastfeeding and human milk use in the NICU is something that I've been happy to be involved in. Virtually every single baby in our NICU at Texas Children's is either getting mother's milk or donor milk, and we're working hard to increase the proportion and percentage of those babies getting their own mother's milk. We know that mommy milk is the best. We know that it has all the nutrients that the baby needs. It may need a little supplementation as far as calories and protein, but basically it is the food of choice. Current and planned initiatives, you've heard some of those. The maternal early warning system, MUSE, which is integral into what we're trying to accomplish across the state. Mental health screening and referrals in the NICU, not just in the postpartum or prepartum unit. Postpartum access to health care, which I think is vital, and increasing access to reproductive health care, which seems to be an uphill slog. The infant admission temperatures guidelines are ongoing. So have we been successful in carrying out projects as a collaborative? Well, I'm going to give you a couple of examples. Here's 3 papers, all published in 2019, 2019 and 2017, that go through some of the comorbidity indexes, maternal risk factor indexes, characteristics associated with induction of labor and delivery route among primates. Those are peer-reviewed publications, scientific conferences we've presented at. There are at least 3 posters out in the foyer that go into more detail, the projects that are been presented at these scientific conferences. And these are another 3. And so there were 16,300 unique visitors to the TCHMB webpage. It's tchmb.org. And the TCHMB News is another way that we communicate with whoever wishes to join us. And there are quarterly 4,406 subscribers. So the TCHMB started where we've gotten out of the immediate NICU. We've gotten out of the step-down nursery. We've gone home, but we still have infancy to traverse. We still have potholes. We still have challenges, but we still have expertise. We have talent. We have the will, and we have the way to make life a whole lot better for babies and mothers. These are our goals for 2020. Refine criteria for selecting projects, coordinate activities even further, identify real-time data infrastructure, increase recruitment of health professionals of all kinds, patients and family members, increase membership and stakeholder involvement, utilize data, outcomes, and evidence-informed and evidence-based processes to inform policy. Focus on reducing health disparities, and lastly, align with shared goals of partner organizations. Thank you very much. Now we are going to have a moderator because I don't have the script for the next presentation. Questions? There's a whisper in the audience, I have a question.
So thank you very much for highlighting the work of TCHMB. I notice you mentioned disparities a lot, and this is an area of interest of mine, the huge disparities between blacks and whites. That black women die at 4 times the rate as white women, and they deliver prematurely, low birth weight, and very low birth weight. So I see bullets that we're going to address it, but I don't see any actual programs that we are going to implement. I didn't see anything, for example, on AIM about that. Can you address that a little bit?
The question is, I mentioned disparities a lot. The comments were that we really didn't have any programs that specifically looked at white women's pregnancies versus all pregnancies. You're correct. We're not picking one population group over another. The causes of the disparities are multiple, as I think everybody in the audience is aware. And one of my colleagues, Dr. Charlita Guillory, this is a passion for her, and she has devoted her entire career to try to help decrease the disparities, not eliminate, because right now we haven't figured out a way to do that. I think an emphasis needs to be on those with the most need, and that would certainly be the black population. But I don't think we should throw out the water or the bath water to, and save the baby. I think we need to direct our attention to all mothers, but with an emphasis on those that need it the most. And I think the programs, the AIM programs, and that sort of thing do just that. Because as you noted, the incidence of morbidities is higher in the black population than in others. Therefore, it behooves us to pay attention with any program that reduces mortality, maternal mortality or morbidity. I hope that partially answers your question. Other questions? All right, thank you again.